So, dear ladies and gentlemen, dear chairman, thank you for being here, and I would like to talk about the prognostic value of new biomarkers in patients with chronic heart failure. I have nothing to declare. These data came from the FAR-NHL registry, which is a quite big database of pharmacology and neurohumoral activation in patients with chronic heart failure. It was done by 3 big university hospitals in the Czech Republic by their cardiological departments, and total number of 1,100 patients were included. The inclusion criteria for the patients were a stable systolic chronic heart failure with ejection fraction under 50%. They had to be on the optimal pharmacotherapy and stable at least for 1 month. As you can see, most of the patients were men. They were classified mostly as NIHA 2 or 3, so it was a stable patient. The mean age was about 65 years of age, and the most common etiology was ischemic heart disease, followed by a dilated cardiomyopathy. The primary endpoint in 1-year follow-up was the death in Evercourse, cardiac hospitalization, left ventricle assist device implantation, or orthotopic heart transplantation. Achieving this endpoint in 1 year, we have divided these patients into 2 groups. The group A with the patients who haven't achieved the primary endpoint. It was about 90% of the patients, and the group B that have achieved the primary endpoint in 1 year follow-up. To all the patients was done the basic cardiac examination together with ACG and laboratory, as well as the standard laboratory, standard biomarkers, and some of those also the new biomarkers I'm going to talk about. The first new biomarker was Copectin. Copectin is a C-terminal fragment of preprovasopressin. It's synthesized by the hypothalamus, and during axonal transport is proteotically cleaved into vasopressin, neurophysin, and copeptin. So copeptin shows us the level of vasopressin, which we know is important in the fluid management in the patients. But vasopressin is very difficult to determine. Nevertheless, copeptin appears to have much more better stability and is more simple for detection, so it's suitable for laboratory detection. And in our register, we have discovered that the patients who have achieved the primary endpoint in 1 year follow-up had a significantly higher level of the copeptin compared to those who haven't achieved the endpoint. Second of these new biomarkers was mid-regional proadrenomedulin. Adrenomedulin itself is a vasodilatator peptide synthesized by endothelial and vascular smooth muscle cells. Its expression of adrenomedulin is stimulated by volume overload, so it's a marker of the congestion, we can say. And adrenomedulin, same as copeptin or vasopressin, is also derived from a larger precursor peptide called preproadrenomedulin. And mid-regional proadrenomedulin is one part of this precursor and is stable and reliable surrogate for measurement. And in our register, again, we have discovered that patients who have achieved the primary endpoint had a significantly higher level of the mid-regional proadrenomedulin compared to those who haven't achieved the endpoint. Third of these new biomarkers is pentraxin-3. Pentraxin-3 is a member of the pentraxin family, like, for example, CRP. This family has the typical pentraxin structure. Sometimes it's also called a tumor necrosis factor. It's released by mononuclear phagocytes, dendrit cells, fibroblasts, and endothelial cells, and behave as a protein of an acute phase, which increase rapidly during endotoxic shock, sepsis, and other inflammatory and infectious conditions. So it's a marker of the inflammation. And the data from our register has shown that the patients with the worst outcome who have achieved the primary endpoint, death, hospitalization, LVAD, or heart transplantation, have significantly higher level of pentraxin-3 to those who haven't achieved the endpoint. 2 last new biomarkers we have set was SLOX1 and 3-nitrotyrosine. SLOX1 appears to be involved in atherosclerotic peaks, vulnerability, and rupture, and is dramatically elevated in patients with acute coronary syndrome. 3-nitrotyrosine is a product of tyrosine nitration and is identified as an indicator or a marker of cell damage, inflammation, as well as nitric oxide production. So it's a marker of an oxidative stress. And by these two new biomarkers, we haven't discovered the difference between the patients who have achieved the endpoint to those who haven't. So it wasn't statistically significant. So to sum up, high levels of new hormonal substances, Copectin, mid-regional proadrenomedulin, and pentraxin-3 might identify heart failure patients with high risk of adverse outcomes, and they might have a potential role as a part of an integrated approach to the assessment of chronic heart failure. In SLOX1 and 3-nitrotyrosine, we were not find their predictive value of prognosis for stable patients with chronic heart failure. Thank you for your attention.
Thank you. And now the presentation is open for the discussion. And while we wait for any question, I ask you something. I noticed that the last two biomarkers were not significant, but for instance, for LOX1, could you try, but it's more a suggestion than a question, could you try to stratify also for the drugs that patients use at the moment that you perform the analysis? Because, for instance, for LOX, if you are using statins or things like that, they could influence your results, for instance.
Yes, that might be a possibility. What we have done, we have divided the patients according to their comorbidities, and by these patients, we have discovered some differences in the significance by these new biomarkers. For example, in patients with lower comorbidities, they have the prognostic value, but in the patients with the higher comorbidities, maybe into more adverse heart failure, they have lost their prognostic value.
Thank you.
I just wanted to ask you, according to your mind, what is the future place for these humoral substances? Could they replace, for example, natriuretic peptides, or what it is?
Well, honestly, I don't think they can replace natriuretic peptides, because in our study, natriuretic peptides were superior to all the new biomarkers, but we think that they may add additional information to the patients. Maybe if we will divide them to other groups according to comorbidities or pharmacotherapy. We can then find the groups with worse prognosis according to these new biomarkers, again together with natriuretic peptides.
Thank you. If you don't have any other question, we can move. We can say thanks again to